So we are going to kick it off with a section on knee and then a section on hip today, and then a section on bracing and exercises, all to do with the lower extremity. And I'm going to start by talking about the top 5 knee problems in primary care. I have no disclosures. And at the end of this talk, you'll be able to list 3 treatments for patients with patellofemoral pain syndrome, write a physical therapy protocol for a patient with a meniscal tear, describe the history of a patient with a meniscal root tear, list 3 exam findings for a patient with knee osteoarthritis, list the keys to ordering x-rays for a patient with knee osteoarthritis, and identify the key exam maneuver used to diagnose a patellar or quadriceps tendon rupture. And to just make sure that you get the take-home points, I did put let's see if I can go forward, a gold star on all of the take-home points. So, if you're zoning out, just focus in on those gold star slides. So I built this talk around the 3 most common causes of knee pain globally, and those are osteoarthritis, which affects 23% of adults greater than 40 years old, patellofemoral pain, which has a lifetime prevalence of 25%, and meniscal tears, which affect 12% of the adult population. And then 2 bonus conditions, so ACL tear and quad and patellar tendon rupture, because I think they're important. If you don't already have a framework for how you organize your thoughts with respect to the musculoskeletal evaluation, I would suggest this, which is HIPROT. HIPROT stands for history, inspection, palpation, range of motion, other tests. And I can remember, being a student and a resident and even a fellow, and there's a lot coming at you, you're taking a lot in and just reciting, okay, history, inspection, palpation. If you do that and then you document that way and you present that way, you will have a comprehensive evaluation. So that's HIPROT. When we think about the 3 key knee conditions, here's how they compare and contrast. So patellofemoral pain syndrome is a younger patient. This is an overuse injury. These patients will have soft tissue swelling, but generally no effusion. They may endorse locking, but it's not really true locking. When I ask a patient, hey, is your knee locking? And they say yes, I say, well, tell me about it. Tell me about the last time that happened. Most patients with patellofemoral pain will say, well, when I get up from standing, it feels like it's making noise or it's catching. So that's different. The locking that's a red flag is, hey, my knee gets stuck and I can't move it. And that's where, there's a piece of, loose cartilage or a bony piece in the joint. These patients also may have instability, but typically this is instability downhill, downstairs, sort of in an AP direction. Also not really the red flag I'm looking for. What about meniscus tear patients? So these patients can be any age. They may have an acute injury. This may be more of a wear and tear process. They may or may not have an effusion. They will be locked if they have a bucket handle tear, and we'll talk about a bucket handle tear. They don't usually endorse instability. And then lastly, our patients with knee osteoarthritis, they may be older, they may have a history of trauma, and so they have post-traumatic arthritis. This can present either with a story of an acute flare or more of an insidious overuse type history. They may or may not have an effusion. Again, these folks may endorse locking, and again, usually what they're talking about is crepitus. And same as patellofemoral pain, they may endorse instability, and generally what's going on is if you ask, oh, tell me about the last time your knee was unstable, they'll say, well, I get pain and then my knee feels like it's unstable, it's going to collapse. The red flag for instability is really torsional instability. So that's a sign of ligamentous tear. I'm walking around a corner and my knee feels like it's shifting. It's the shifting description that I'm really listening for when I'm speaking with a patient and asking about instability. This description of, it feels like my knee shifts in an odd and uncomfortable way. What about common causes of knee pain by location? So anterior knee, we're going to talk about in detail. Lateral, we won't talk in detail about IT band syndrome, but I do want you to know that in a young, active person, the most common cause of lateral knee pain is IT band syndrome. And we'll talk about that as well in the physical exam part. Medial pain could be a meniscus tear, could be knee OA and MCL. And then posterior, I think, is your broadest differential. Posterior knee pain could be a lot of things. All right, so let's do some cases. So this first case is a 15-year-old high school student who has anterior left knee pain for 3 months that started as she was increasing her running mileage during the cross-country season. She denies swelling, she denies locking, but the knee is popping. She does have instability when she's walking downstairs. The pain is worse up and down stairs and worse with prolonged sitting and with squatting and with kneeling. You do her exam. She has pes planus and hindfoot valgus and slightly valgus knees. Mild left quad atrophy, tender patellar facets, no effusion, intact range of motion. She has no meniscal findings, no ligamentous laxity, a positive Ober, and a stable single leg squat, but anterior pain on the left with that. All right, so we're going to try to launch a polling question. So we'll see how this goes. This is meant to be done in the app. And so I think if you go to Whova to this talk and look for polling questions, you should be able to log your response.
On the home page is a polls.
Okay, on the home page there's a polls. And Scott, are you able to launch results? Oh, they're there. Awesome. Cool. Thanks, everybody. All right. So, yes, totally agree with where people are going here. So this really describes patellofemoral pain. Could it be chondromalacia? It could, but she's a little bit younger, probably. What's the difference? Well, chondromalacia patella is really an MRI diagnosis. Presents the same way. It's just that patellofemoral pain really would have a normal MRI, and chondromalacia patella would have a little bit of fissuring or a little bit of changes on MRI in the patellofemoral joint. Why isn't this the tendinopathy? Well, she wasn't tender. I didn't tell you she was tender on the patellar quad tendon. And not PES, just because I didn't tell you she was tender on the PES. So some classic findings of patellofemoral pain. What are the history keys? This is anterior knee pain. It might be anterior medial, it might be anterior lateral, but in general, it's the front of the knee that hurts. Important to talk about training history and their occupational load. So this is really an overuse injury. There should be some sort of story that has to do with more load on the joint than usual. Or that maybe they fell. Maybe they fell right onto the patella and have some sort of cartilage injury. That would be more like chondromalacia or cartilage injury of the patellofemoral joint. It's good to inquire about shoe life. Are they wearing their shoes for much too long? And then sometimes patients will come in. I think we've all had patients who come in with patellofemoral pain and say, "Well, I've done PT, I've done rehab," and I think it's good to inquire, well, tell me more about the rehab. Like, can you show me what you did? Can you talk me through the program? Because sometimes it hasn't really been a comprehensive program, or maybe they received a handout but didn't have a chance to go back. So just exploring, okay, tell me about what that physical therapy was like to see if you feel like, yeah, that was high quality rehab. And then also good to identify what this person's goals are with their training and with their occupation. What's the pathophysiology of patellofemoral pain syndrome? So it's maltracking, and that plays a key role in both patellofemoral pain syndrome and patellofemoral osteoarthritis. The concepts are that the patella has increased lateral tilt and increased lateral displacement. So a few biomechanical concepts. First is this concept of the Q angle, which some studies show does increase the risk of patellofemoral syndrome, and others say it does not. But the Q angle, as shown in the picture, is the angle between your anterior superior iliac spine, the front of your knee, and your ankle. The more knee valgus, or the higher your Q angle, the more the vector goes laterally on the patella. And so it'll theoretically put you at risk of having lateral patellar displacement. The other biomechanical factors that increase the risk of lateral patellar tracking are femoral internal rotation, which can happen because of weak hip abductors or weak gluteus medius, and tibial internal rotation, and that can be because of a flatter foot or hindfoot valgus. So when we think about the physical exam, which Dr. LaRoque is going to demonstrate, when we think about this for patellofemoral pain, these are really the keys. You're really trying to figure out, okay, what's the biomechanical problem that's causing this for this patient? Do they have weak hip abductors? Do they have quad atrophy? Do they have flat feet? And these are things, these are obviously modifiable risk factors. So treatment, the goal is to promote more medial tracking of the patella. And this is usually done in a multimodal way. So first, physical therapy, really looking to strengthen the glute, strengthen the medial quad. Taping or bracing, which I'll talk about. Aligning the feet, so if they have pes planus, thinking about an over-the-counter orthotic to provide support. Activity modification. And then really, if the patient tries this for 12 weeks or so and they haven't improved, that's when I would think about imaging and a sports medicine consult. A little bit about patellar taping. And anyone in the room use patellar taping with their patients? A few. So patellar taping can be a useful tool when your patient's having lateral tracking. And there's really two styles. You see them pictured here. Picture A is called McConnell taping. And this is sort of the most popular and the most classic patellar taping style. This is where you basically pull the patella laterally. You can tilt it a little bit. Evidence supports use. So when I recommend this to patients, I suggest that they do this before they work out or before they have a competition. It's useful in the short term, but long-term effects aren't clear. And then an alternative to McConnell taping is kinesiology taping. Different concept with kinesiology taping. In this situation, and this is shown in picture B, these tape strips are used to increase the space between the muscle and the fascia and to cause muscular activation. So this has been shown to reduce pain and improve function and often is used in combination with exercise and or physical therapy. Yeah.
How does it increase how does it help, did you say?
Yeah, so the question is, how does this help? So in the case of McConnell taping, it helps by medializing the patella. So you're basically like creating a buttress so that the patella is pushed in. And I tell patients like, look, this isn't going to be what you want to do for your whole life. But while we're waiting for your glutes to fire and your medial quad to fire, this is a reasonable short-term thing to try. See if you can play. I'm less clear on how kinesiology taping separates muscle from fascia. However, the idea here is sort of anteriorizing, bringing the kneecap forward, creates space, and so allows the patella to glide without causing that friction and pain. My approach, if someone benefits from the taping, particularly if someone benefits from McConnell taping, but they prefer to have a brace, I'll write them for a patellar stabilizing brace. When you look at the data for bracing for patellofemoral pain, it's pretty mixed. All right. So we're going to move on to case number 2. This is a 35-year-old man with medial-sided pain and swelling of the right knee for 4 months since he twisted his knee in a squat. He endorses catching. He has no locking and no instability. His symptoms are ongoing despite 12 weeks of physical therapy, and he brings with him normal knee x-rays. You do his exam and find that he has an effusion. His range of motion is slightly limited because of the effusion, and he feels tight. He has a tender medial joint line and no bony tenderness, so non-tender medial femoral condyle, non-tender medial plateau. He has medial knee pain with McMurray, squat, and Thessaly, and no ligamentous laxity. Okay, so again, if you would go into the app and take a look at the questions. The question is, what do you recommend next? A compression sleeve, B, a medial compartment unloader brace, C, a knee aspiration and steroid injection, or D, a knee MRI? All right, great. So yeah, different thoughts here. I agree with the majority of you. 88% of you said knee MRI. That's what I would do as well. We'll talk about why I would do that. I think you could argue for other options. I think there are situations where maybe an aspiration and steroid injection would feel like the right thing, particularly if you're sure that this isn't some sort of meniscus tear that needs surgery, or if the patient really prefers no surgery if it's not the patient's not a surgical candidate. An unloader brace could be helpful symptomatically, though I would say for a younger patient who's pretty athletic, the unloaders aren't as useful. So key physical exam maneuvers for meniscus tears, we really think about these 5 things. So is there an effusion? Is there joint line tenderness? McMurray, Thessaly, squat, and Dr. LaRoque will demonstrate these, but using all of these can really, as you stack up positives, you get more and more concerned, okay, this is seeming like a meniscus tear. And really your history and physical exam are key because meniscus findings are so common on MRI. More than 30% of patients 50 and older without osteoarthritis have meniscal pathology on MRI, and greater than 60% of patients with knee OA have meniscal pathology on MRI. So, your history and your physical exam are super important in this situation. We think about really 2 major kinds of meniscal tears, acute and degenerative. Acute being, there was some, as in this case, there was some kind of trauma, albeit, just a squat, but there was some moment where this happened. Degenerative being like, it's more insidious. Acute, we tend to think of as patients who are younger, degenerative as we get older. Both can have an effusion, although the acute tears tend to have an effusion right away. And both can have mechanical symptoms. Patients will endorse like catching and locking. But really, it's somewhat debatable. And when you read the literature on this, there's no clear diagnostic validated criteria on what is an acute meniscus tear and what is a degenerative meniscus tear. And that becomes important when you think about who benefits from surgery and who doesn't benefit from surgery. But I would say, on this slide, the more factors that are lining up on sort of the bright green, the acute, we tend to refer those patients more for surgery, whereas the ones who are more on the right, the more degenerative, we tend to treat with non-operative treatment. The vast majority of patients with meniscal tears benefit from non-operative treatment. So, of course, acutely calming down the pain and swelling, modifying activity, and then there's really a big body of literature now showing that physical therapy benefits patients as much as arthroscopy for meniscus tears. Typically, this is a 12-week physical therapy program that's quite intensive, and I'll talk about a few of these protocols. But again, similar reductions in pain compared to partial meniscectomy in adults. And then sometimes injections, and particularly if there's concomitant knee arthritis. I wanted to present this paper. This was published in the New England Journal in 2022 because this paper focused on physical therapy protocol for patients age 18 to 40. I think for probably 5, maybe 10 years, we've known that patients in their 50s, 60s, 70s, 80s who have degenerative meniscus tears and arthritis benefit from PT. But what about the younger patients? What if I'm 20 years old and I have an acute meniscus tear? Do I benefit from PT? And this paper would say yes. So these patients were 18 to 40. They went through 12 weeks they were randomized. Half went to PT, half had arthroscopic surgery. You can see that the PT protocol, this is no joke. They're going twice a week for 60 to 90 minutes. So, this is different from what most of our patients can access and what most of our physical therapy therapists have, the bandwidth to provide. But in a study situation, this is what they're doing. So I think it's important when we try to operationalize this to recognize, okay, there's some limitations to implementing this. But a very robust rehab protocol can be as beneficial as arthroscopic surgery. The other important thing to notice or to note about all this data is that in each of these studies where they randomize patients with meniscus tears to PT versus surgery, in each of these studies, and there are probably, there might be 8 or 10 of them now, 30% of patients who get randomized to PT cross over to surgery. So I always remember that because, typically I'll recommend non-operative treatment for these patients, but remembering that 3 out of 10 people won't get better until they have surgery. And so to make sure that we follow up with folks and make sure that they're benefiting from the PT, and if not, to consider sending them for arthroscopy. And then this paper was just in the New England Journal in October. So this paper really speaks about home exercises. What these researchers did was they randomized patients, these are 45 to 85-year-olds with meniscal tears and osteoarthritis. They randomized them to home physical therapy versus office-based physical therapy and showed no difference. And so I think this is encouraging to say, all right, sometimes it takes the time to get into PT and so on. So if we can arm our patients with a really robust home exercise program, as they did in this study, they can benefit too. I did put this protocol in your handout. So again, no joke. This is the tempo slides, and it's 28 slides that's in your syllabus that talks about the home exercise program. The slide deck is detailed. They use ankle weights. I do think it's all approachable. It's all stuff that I think my patients could do at home. So worth looking at and thinking about when we have our patients who maybe, have barriers to office-based PT. What about surgical treatment? So I talked about 3 out of 10 of these patients crossed over in these studies. So remembering that arthroscopy is an option for these patients if they're not getting better with PT or home exercises. I would consider that after 3 to 6 months of exercise therapy. And the studies all say, too, they have a lower threshold for arthroscopy and when patients have mechanical symptoms, catching and locking. And then definite referral, urgent referrals when there's a concomitant ACL tear, a bucket handle tear, and a meniscal root tear. So bucket handle tear is shown here. This is where the meniscus tears and a piece of it flips up like the handle of a bucket. Typical story, this is a younger person. There's been an acute injury. Usually this is medial, so they'll be tender medially. They will have a locked knee. They won't be able to fully extend. They will have a moderate to large effusion. These patients should be put on crutches. They should have urgent X-ray and MRI. They should have an urgent referral to sports medicine surgeon. What about meniscal root tear? Have folks taken care of patients with a meniscal root tear? A few. Meniscal root tears are kind of a hot topic in the world of sports medicine. So the meniscal root, the ones we're talking, the meniscus has 2 posterior roots. So there's a medial posterior root and a lateral posterior root. The root is key in stability of the meniscus. And if you have a root tear, it essentially is like having a complete meniscectomy. It makes the meniscus completely non-functional. So, but it can be repaired, but they're hard to pick up on history and physical, I will say. So just to have this in mind, these patients are usually in their 40s, 50s, maybe 60s. They come in and see you with acute knee pain. It can be posterior. The root is posterior. As you in the picture I drew here, the meniscus is purple and the roots are sort of those pink things way in the back. This is a posterior view of the tibia. So they'll come in 40 or 50 years old, relatively little trauma, like, I stepped off a curb and felt my knee pop. And now I'm getting really bad posterior pain and my knee is swelling like crazy. So when you meet these folks, you'll do an X-ray, they won't really have any arthritis. Maybe, typically I'd be like, okay, this person probably has knee arthritis. You get an X-ray, there's no knee arthritis. These are folks to get an MRI on because maybe there's a root tear and that needs to be fixed and it needs to be fixed sooner than later. Because if we don't fix the root tear, they're at risk of breaking down that compartment and getting arthritis rapidly. All right, our third case. So this is a 60-year-old woman with 6 months of medial knee pain. She has swelling and instability, but no locking. The pain's worse with weight bearing and better with rest, ice, and NSAIDs. She's tried home exercises and PT, but has ongoing pain limiting her function, and she wonders what else you'd recommend that might help. On exam, she has neutral knee alignment when she's standing. She's tender at the medial joint line, the medial femoral condyle, and the medial tibial plateau. She has a small effusion, little crepitus. She has a positive McMurray, medial knee pain with squat, a positive Thessaly, and no ligamentous laxity. Okay, so again, a question for you. So what would you do next? Would you order knee x-rays, order a knee MRI, refer for arthroscopic debridement of the meniscus tear and lavage, or refer for total knee? Oh, okay, yeah, we have some disagreement. This gets interesting. So half would do a knee x-ray, 60% of you would do a knee x-ray, 34% say knee MRI, and I'll talk about talk about that. I think the test of choice here would be to do a knee x-ray, and why. And the reason is you want to know if she has osteoarthritis, and her exam would make you think she does. So she has both, In green here are the findings consistent with osteoarthritis. In black are the meniscus findings. So she has both medial compartment OA and a medial meniscus tear. Here's the criteria for diagnosing OA. So it's really bony tenderness is what you're looking for on exam, crepitus as well. What does an x-ray get you? An x-ray increases your specificity. So you can be very sensitive. The sensitivity of the exam, it's 95% sensitive, but you increase your specificity if you get an x-ray. And so I would recommend an x-ray in this situation. Which x-rays? You want to get weight-bearing x-rays and 3 views so that you can appreciate the medial, lateral, and patellofemoral compartment. But always, if your patient can weight bear, always weight-bearing x-rays. The reason is it'll be much easier to tell if they have osteoarthritis than if they're non-weight bearing. How do we treat knee OA? So I think, I always think about knee OA treatment in sort of 2 big buckets. There's non-pharmacologic treatment and pharmacologic treatment. Non-pharmacologic treatment, we're talking about weight management, talking about educational programs, exercise, Tai Chi, yoga, bracing. And then pharmacologic treatment, my go-to is topical diclofenac gel. And, oral NSAIDs, yes, but often people have contraindications. So really topical diclofenac gel is often my go-to. Injections, so the data not as strong for most injections. We'll talk a lot in this conference as the days go on about different injections. This is at a JAMA, and so they're looking at big data sets. Our injection data is smaller studies and not as strong as, say, the data around weight loss and weight management. So weight management, what do I tell patients? Well, if you have a BMI 25 or greater, you'll have benefit if you lose 5% or more of your body weight. And the benefit is decreased pain and improved function. This also, in one study, has been shown to reduce the risk of osteoarthritis progression. I think many of our patients are wondering, what is disease modifying? My knee is okay, I'm managing the pain, I want to know what I can do to prevent me needing a knee replacement. And I think this is one of those things, so weight loss. You probably saw in the New England Journal, big study looking at semaglutide, weight loss, and benefits for knee OA. They weren't really looking to see, did the independent of weight loss, did semaglutide lead to to improved function and less pain with knee OA? This was really when you give semaglutide, patients lost weight and they had decreased pain and improved function with their knee OA. These were patients with a BMI of 30 or higher. Supplements we'll talk about as the course goes on. I would say there are small benefits from these supplements, but what's not clear, A, the data is not super great, B, the benefits are small and it's unclear if they're clinically meaningful. But I would say come to Dr. Osterhaus's talk, come to our registered dietitian Lindsay Orbeta's talk, and they'll talk more about supplements. Okay. So a few last points with red flags. First, this is a 17-year-old female basketball player who landed from a rebound and felt a pop. She had immediate swelling, the knee feels unstable. On exam, she has a large effusion. Her range of motion is limited to 10 to 80, and the knee is just generally tender. You really can't do much of an exam. You can't really do her meniscus, but her Lachman is positive, as is her anterior drawer, and the rest of her ligaments feel stable. And so this is a classic description of a patient who's torn her ACL. Non-contact, felt a pop, large effusion. If you have that story in your clinic, honestly, I don't think it matters too much what the exam is, except for they have a large effusion. This patient needs x-rays, needs MRI. Lastly, I wanted to remind you about patellar and quad tendon ruptures, so that this is in your differential for your patient who comes in having had a traumatic event and really having trouble walking. These patients will have landed on a planted foot with their knee bent and felt a pop. They will have an effusion and be unable to straighten their leg. That's the key exam maneuver with these patients. So always, when you're meeting these patients who've come in, they felt a pop, the knee is acutely swollen, check their straight leg raise. Can they raise the leg up against, your resistance? If yes, they don't have this. If no, think about quad or patellar tendon rupture. You probably also can feel the defect in these situations. This is a surgical urgency. Get them to your sports medicine surgeon. All right, that brings me to the end. I'll leave you with some resources. These are all in your syllabus. So for those of you who like podcasts, the Curbsiders, I did a couple episodes with them last summer. So more sports medicine on the Curbsiders. And I think we covered the objectives. And this is a reminder to tell me that those exercise slides for the Tempo Study home exercise program for your patients are in your syllabus. So thanks for your attention. And I'll take a few questions. I know that Dr. LaRoque is going to come up and set up for the exam, but I'm happy to take a few questions as folks come up and set up. Yes?
I'm getting several patients with medial facet osteoarthritic changes on the medial portion of the patella, but most people track laterally. So what is the mechanism for medial facet wear?
Yeah, that's a good question. So why? So he's saying he has patients who have medial facet tenderness or wear on their imaging rather than lateral. I think I see the same thing, and I think I treat them sort of opposite the classic. I think it's less common than lateral wear, but yes, you will have I think it's basically the opposite mechanics of what we see with.
But they're very valgus still. So
Yeah.
Valgus leg.
Yeah.
Should be a lateral facet wear.
Yeah. And then they still, I don't know. I don't know why that is, but I would hesitate, like for those folks, I don't recommend McConnell taping because you're just going to load that medial facet. But you could think about the kinesiology taping, which is going to bring everything forward. Yes?
Shockwave seems to be coming up on the scene a lot more nowadays. So what do you think of shockwave specifically for OA in the knee joint?
That's a great question. Shockwave is really on the scene. So I would say mostly we are recommending shockwave for tendinopathy. I have not been recommending it for knee OA. But I will say disclosures, we don't perform shockwave in our office. So I'm also not up on all the smallest studies. But for tendinopathy, there is some good data for it. For those not familiar, shockwave, it's the same technology as like lithotripsy. So it's, ultrasound, I think, shockwave, pulsed ultrasound, pulse waves, that the same thing you use to break up a kidney stone, but can be applied to a tendon. And, really promising results in tendinopathy can be uncomfortable, but even in-season athletes can couple shockwave with physical therapy and have some good benefits. Thanks for the question. Okay, you ready?
Sure.
All right, I'm going to turn it over to Dr. LaRoque.
Great, we'll see if my mic works. I think it does, thank you. All right, so now we're gonna start the hands-on physical exam session for the knee. So I'm gonna walk you through it, and then, we'll try to take a few minutes for questions at the end as well. So let me stand down here. And this is Donna. She's gonna be the model for today. And as Carlin was talking about specifically, for example, with patellofemoral syndrome, for physical exam of the knee, I always do like to start just looking at the patient standing and just looking at, for example, their arches, and then watching them walk. That just gives you an idea of, say, Q angle, things like that. In interest of time, we will skip the walking with Donna. And then for the next part of the exam, I actually do start with them sitting, just as she is now. And then if they still have, say, baggy pants on, something like that, I do like for them to roll both pant legs up or have shorts on, okay? Because you always want to compare to their non-affected side. So for today, in the sitting position, let's pretend that it's your right knee that's having an issue. So first, I would just look at both knees, see if I see any swelling, any redness, and then I would go to palpation. So for palpation, I'm going to point out just a few different things. So I do like to palpate over the patellar tendon, over the quad tendon, as Carlin was saying. Sometimes they'll have pain there, or you can have a defect if they have a quad tendon tear or patellar tendon tear. And then I like to palpate along the joint line. So this would be the lateral joint line. And we can help you with landmarks and finding these in the hands-on sessions too. And then I'm going to feel her medial joint line. And then I also like to feel the pes too. So that's a little bit inferior and anterior to the medial joint line. So if somebody has distal hamstring pes bursitis, sometimes they'll be tender there. The other thing I like to have them do when they're sitting is just simply straighten the knee. So go ahead and straighten your right knee. Good, and then bring it back down. And then straighten your left knee. Good, and then bring it back down. So if Donna had, say, a patellar tendon tear or a quad tendon tear, she would not be able to actively straighten the leg as she just did. And then the other thing is when you have them straighten the leg in that position, it just gives you an overall idea of patellar tracking. So there's something called a J sign or jumping J sign. We can go through that with you more later. But often when people are sitting and the knee's bent, then the kneecap's actually kind of captured in the trochlear groove. And as they go into extension, it jumps out of the groove laterally. So it's called the J sign. So I do like to do a quick knee extension test in the sitting position. Now we'll move on to supine. So let's have you lay down, yeah, correct, with your head up here and on your back. And for this part of the exam, we're gonna say that the left knee is the affected knee. So again, I like to have both pant legs up or shorts on, see if anything looks swollen. And then I do like to just check for swelling. So there's basically a milking test where you can milk any fluid on both sides under the patella, and then I just push down on the patella, and you'll feel a little tick where it's going through fluid to hit the trochlea, and you can literally feel it ticking off the trochlea. So especially if it's a young person and they've had an acute sports injury and they have an effusion, that's actually somebody that we would want to see in clinic. Next, I like to check the patellofemoral joint. So I just do a simple patellar grind test where I just push on the kneecap, move it side to side, see if that elicits pain or grinding, and that could indicate patellofemoral syndrome or maybe patellofemoral arthritis. And then I'll often do a quick test for patellar instability. So it's actually supposed to be done at about 20 degrees, okay? So sometimes I'll very slightly put my knee under her knee just to slightly bend her knee. And then the most common direction that people have patellar instability is lateral. So you just gently kind of push on the kneecap laterally, and there's a quadrant rating system based on the width of the kneecap. So you just estimate, do you think it's going over laterally about a quadrant, 2 quadrants, so 25%, 50%, 75%. And then you can also see if they have a good endpoint or not. So that would be the basic test for patellar instability. Then I like to check range of motion. I like to compare to the other side too, because some patients, their knee will actually hyperextend. I'm just gonna move this chair out of the way for a minute. Okay, so we'll check her range of motion, check to see if she has hyperextension, not really, and then flexion. Okay. And then I like to check the ligaments next, okay? Because these tests really shouldn't be very painful, and I like to do the non-painful tests first. So while she's at about 90 degrees, I'm gonna check anterior drawer, that's one of the tests for ACL, and posterior drawer, that's one of the tests for PCL. So I'm gonna secure her foot distally, and then I'm gonna pull forward on the tibia, that would be anterior drawer, and then push posteriorly on the tibia, that would be posterior drawer. Then I'm gonna move on to Lockman. So Lockman's described with the knee flexed at about 30 degrees. So especially if the leg is, say, big, muscular, heavy, I will often put my knee under the very distal femur. And then I just put my hand over it, and that secures the distal femur, because the Lockman, you want to secure the distal femur, and you only want to really be moving the tibia. Okay, so then I'm going to move the tibia forward, and then you can see if it feels like there's increased excursion in terms of millimeters, and then you also want to see if it has a good endpoint or not, and then you can compare to the other knee. So there's a grading system. You've probably seen Lockman A, B. So A is it has a good endpoint when you pull the tibia forward, and B is it has a poor endpoint, okay? Then next I'll go into McMurray because, and then actually, while she's at 30, I just did Lockman, I'm gonna do varus and valgus, okay? So we do varus and valgus stress at 30 degrees and then at 0 degrees. So she's at 30 degrees right now. So I'm gonna go ahead and first valgus stress her. And I remember valgus has a G in it, so it's like gum sticking the inside of the knees together. So she's going into more of a knock-knee position, okay? So I'm doing valgus stress at 30 degrees, and then I'll do varus stress. That's making her go more bow-legged at 30 degrees. And again, you wanna check for how much excursion you're feeling when you're doing these tests, but also if these tests have a good endpoint or not. And then very quickly, I will also do varus and valgus stress at 0 degrees. And if somebody opens up a lot at 0 degrees compared to, say, the other side, then that's actually a red flag that they might have, say, a multi-leg injury or had a history of a knee dislocation, something like that. So those are patients that we would want to see. So next, because she's still supine, I'm going to go into McMurray. So for McMurray, there are many variations. I was talking to Danny about this today. But the original test is described that you bring the patient into flexion. This is going to be a provocative test for, say, a meniscus tear. So you bring her into full flexion, and then we'll start with internal rotation first. So you can start with internal rotation. That also usually brings her into some valgus, and that will load and pull on the lateral meniscus, okay? And then you bring her into extension. And then you see if she has pain or popping, say, laterally that correlates with her typical symptoms. And then another variation is you do the same thing, so flexion, internal rotation, and some valgus, but you can also kind of do some extra twisting, sweeping motions as you go down. Okay, so that would be McMurray, more specifically testing for lateral meniscus, and then I'll do the same for medial. So I have her up flexed, I'm gonna externally rotate, and then that tends to put her in a little bit of varus, and then I can just twist down and see if she has pain or popping that reproduces her typical symptoms, say medially. Okay, next I'm gonna have you lay on your right side, so you're gonna be facing the audience with your hips sort of straight up and down. Perfect, okay. And then, yeah, you can bend this knee a little bit, and then this leg, I'm gonna have you keep the knee straight, a little bit of extension, and then just hold your leg up. Don't let me push your hip down. Okay, good. So that tests hip abduction strength. And so as Carlin was saying, it's really important, say with patellofemoral patients, that you wanna check that because it also gives, say, myself and the patient even more confidence that if they're weak there and they have patellofemoral pain, that if they had good physical therapy, they'll probably really improve. And then go ahead and lay on your stomach. So lastly, when they're laying down, I do have them go prone, and then I'm gonna do the Elly test. Okay, so this is also a provocative test for, say, a meniscus tear. So you can just relax, and I'm gonna have you I'll bring the leg up to about 90 degrees. And with this test, you wanna push down, so kind of compression across the knee and the meniscus, and you're gonna rotate in, rotate out. And internal rotation, that would tend to load the lateral meniscus more, and then external rotation would load the medial meniscus more. And then I should say also with the McMurray, you also want some compression, okay? So with the Elly and with the McMurray, go ahead and lay on your back one more time. With the McMurray, it is also described and works best if there's some compression. So when I showed you the McMurray, I was holding her ankle, but you can definitely get some compressive force that way, or you can also hold the foot and get some compressive force doing the McMurray by holding through the foot. And then lastly, I'm gonna do 2 more tests. So go ahead and stand up for me. Okay, so next we'll do the squat test. So usually with the squat test, I'll start with her feet at neutral and then about, say, shoulder width apart. Perfect. And then just go ahead and go down into a deep squat. Good, and then come back up. And then you just see if that reproduces her pain. So Danny and I were talking about that, that the squat test actually has the highest sensitivity and specificity for meniscus tear. So it's quick, and I definitely recommend doing this if you suspect meniscus tear. And then go ahead and go a little bit, with your pigeon-toed, and then go ahead and do the same thing going down into a squat. This one's a little harder to do, good, and then come back up. So with the toes internally rotated, that brings the knees into some valgus, and that would tend to load the lateral meniscus more. And then I do the same thing with external rotation. Good, and then just repeat one more time. Okay, so that's external rotation and some varus, and then that would typically light up a medial meniscus tear more. And then lastly, I'm gonna show you the Thessaly. So for the Thessaly, I'll usually start with the non-affected knee first, just so they have an idea of kind of what I'm doing, because to the patients it seems a little bit like an odd test. And then you always want to make sure they're supporting themselves on something or offer support, especially if they have some balance issues. So let's pretend your affected knee is the left knee, and so we're actually going to start on the right knee. So I have them stand up. You can support yourself on my wrists. And then let's have you stand on the right leg only, and then just bend your knee to about 20 degrees. Good. And then go ahead and just twist back and forth with your upper body on your knee. Good. And then does that hurt at all in the knee? No. Okay. And then we'll have you repeat the same thing on the left. Go ahead and bend about 20. Good. Any pain there? Okay. No. So for Thessaly, it would be positive again if they have joint line pain. It reproduces their typical meniscus type symptoms. I mean, patients with patellofemoral arthritis will probably hurt when you do that test too. So it's not totally specific, but it is actually more sensitive than the McMurray. I think those were the exams I was going to highlight, and then I'm happy to take some time for questions. Carlin, do we have time for a couple of questions?
Yeah, we have a good amount of time for questions.
Okay, great. Yes.
So for an acute injury, when's the best time to examine the patient? How many days after, or to get the best result or the best prediction?
Sure. So the question is, if somebody has, say, an acute knee injury, when is the best time to examine them in terms of getting the most information out of the exam? Sure. So a lot of us do sideline coverage, right? Like I do a lot of football sideline coverage. So I would say sometimes if you can get to them right away before all the swelling and the stiffness and the guarding happens, that is pretty ideal. But if you can't get to them right away, then I would just say, if you're worried they have an effusion, it really was an acute injury, or the patient feels unstable, or they might have locking in the knee, then I would just say any time is fine. Just because you'd want to screen them to see if it's something where you think they might need an urgent MRI or need to come in to see us. But usually I would say the most accurate exam is either right away before there's swelling and guarding, or like say for an ACL tear patient, you get a more accurate exam with, say, pivot shifts, something like that, if they're at least a couple of weeks out and the swelling and the acute pain has gone down. Yes?
Do you think it's reasonable to limit to 1 or 2 exams per area? Like for example, if I feel a patient can do a Thessaly, I typically won't do a McMurray because the Thessaly is more sensitive, or do you typically do all of the exams all the time?
Sure. So how many of these exam tests do I do all the time? Yeah. And then one other thing on that note I wanted to point out is we do sometimes at these courses get questions about, hey, if I have a patient with kind of a suspected or known history of knee arthritis, do I do all those tests? No. Okay. I'd probably even skip Thessaly, maybe even skip McMurray. More just testing ligaments and range of motion and just how large of an effusion they have. Yeah. So there are definitely times where I'll skip quite a few of these exam tests, but I'd say my average patient where I'm really suspicious from just their story and their age that their problem is probably, say, a meniscus tear. Then I usually do at least half of those physical exam tests. But as you said, if they're sore and 2 of them have already been positive, then sometimes I will skip the others, especially like Thessaly or Apley, because you have to have them in a different position. But this is sad, but with insurance these days, sometimes to get an MRI authorized or for us to get a surgery authorized, sometimes there are checklists that the insurance reviewers will go through where they literally won't authorize an MRI or surgery if the patients don't have, say, 2 or 3 or more positive tests for meniscus. Yes.
What is the ticking test? I didn't understand what you were doing with the ticking test. It was some way of palpating the patella?
Oh, sure. The milking test.
Well, there's a milking. Then you said something about feeling a ticking or something.
Oh, I see what you mean. The ticking test. Yeah. So I call it. It is called like the milking maneuver, or the milking test, where you're milking fluid under the kneecap. And then I call it a tick. So what happens is if there is fluid that you've collected under the kneecap and you're still sort of supporting the kneecap on that fluid, the kneecap is literally floating over the trochlea. And then when you, with your other hand, kind of push down intermittently on the kneecap, you'll feel this ticking. It'll go tick, 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 and the patient sometimes can feel it too. It's a way to convince them that they really have an effusion and need to stop playing soccer and need to go get their MRI. So I call it ticking, but you'll feel it and hear it go tick, 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 tick with the undersurface of the patella hitting the trochlea. And then you can always compare to the other side, and the other side usually it's negative. You don't feel any ticking. Yes?
In a high school athlete who has signs of meniscal injury, when do you decide to have them go straight to PT versus getting an MRI first?
Sure, good question. So say a high school athlete that they have acute onset of pain and you're suspicious from their story and potentially their exam that they might have a meniscus injury, when do you get an MRI?
Or versus just have them go to physical therapy?
Versus just have them go to physical therapy. You know, if they're a pretty high level high school athlete where they're playing every day, and you really suspect a meniscus injury, I usually get an MRI early, especially if they have an effusion and they have multiple positive physical exam tests. My reasoning is there are some meniscus tears where I would definitely want to think about surgery earlier and where I'm just not that confident that physical therapy is going to resolve their pain enough. But then there are other times where we get the MRI back and say it's mostly a horizontal tear or a small radial tear. And some of those, then I would be okay with them trying physical therapy first. So especially if they're going to keep doing high-risk things for further tearing in the meniscus on a regular basis, I would lean towards getting the MRI early, ruling out a bucket handle tear, a flap tear. They usually wouldn't have a root tear, but just a radial tear. Those tears actually don't do well over time. A root tear is essentially like a type of radial tear. So if they had a large radial tear, I would actually want to fix that because that would help prevent knee arthritis. So I'd say I'm fairly aggressive ordering MRIs on, say, high school athletes. Or how about you, Carlin?
Yeah, I would say, yeah, totally agree. You know, it's interesting. The studies that I presented are adults. And I don't think we have similar studies for kids yet. And I agree with Elly. Like, my red flag is really effusion. I always tell the residents who work with me in clinic, like, if I had like a magic wand and I could give you a skill upon graduation for your exam skills, what would it be? It would be, can you detect an effusion in the knee? Because it's such a good red flag. Like, if you can detect an effusion with confidence, if I see one of my high school kids, one of the WASH kids, and they come off the field and they have an effusion, they're not going back in the game. Got to get imaging, got to see what's going on. And I start with an x-ray. But, if I do an exam and I'm worried about a meniscus tear, I would get an MRI too on a high school kid. Yes.
You mentioned this entity called pes bursitis, and I when I'm palpating the knee, I'm palpating the joint lines, and then they get this pain in the medial aspect, and I'm thinking, there's nothing there. But you're telling me there's an entity called pes bursitis?
There is, yeah. So I can show you, it's a little hard to see, it's small, but on the knee model. But yeah, this would be, say, the kneecap. So this is the medial knee. So here's the medial joint line. And then there is this little kind of ridgy prominence, almost like the equivalent of Gertie's tubercle laterally, where the medial hamstrings come and insert. And there is a little bursa on there that's usually, deflated and flat. But sometimes that bursa can get inflamed. So I've actually had it where I've seen visible swelling there or even a little bit of kind of redness and irritation. So if they're tender below the joint line, you're really confident they're tender over the anteromedial tibia, then I would want to think about pes bursitis. And then the treatment options for that's different, right? You might adjust physical therapy a little bit. Some of our primary care sports medicines will actually do ultrasound-guided cortisone or Toradol injections into the pes bursa instead of into the joint to help calm that area down. Do we have time for one more question,
Yeah.
Carlin? Oh, okay, great. Yes? and just inflammation, sure. Carlin,
Yeah, I
why
think it's, I,
yeah, why don't you
so
take that
I would
one?
think about like a patient with patellofemoral pain. You may notice the patient with patellofemoral pain has like a lot of soft tissue fullness. You know, sometimes the knee will look kind of puffy, but then you feel the knee and it doesn't, you can't swish the fluid around. I think about an effusion a lot like a water balloon. It really feels like as Elly was saying, you can kind of swish the fluid, and I'll put one hand on top of the patella and one on either side of the patella, and you can kind of swish the fluid back and forth. Same way you would with like a fluid wave in the belly, you know, just swish back and forth. So it's really that. It's like, I don't find it very helpful at all to like inspect and decide based on my inspection if there's an effusion. I like the patient, and I don't bother checking at all when they're sitting. I like the patient lying down, and then just carefully feeling, and do I feel that there's swishing inside the knee, that there's fluid swishing around? Okay, thank you so much. I think we're going to switch. So thanks, Dr. LaRoque.
Thanks, Carlin.